Hello, everyone. Thank you for joining. So we're continuing on with urgent eye care, and we're talking specifically about penetrating trauma and intraocular foreign bodies. We spoke about blunt trauma the last time, so I'm sort of continuing on looking at globe rupture in the context of penetrating trauma today. So just going back to that sort of classification system that we spoke about in the blunt trauma session, what we're looking at here specifically is sort of your penetrating injuries. So a specific object penetrating into the eye and kind of causing all sorts of problems, and then how you sort of manage this in the clinical environment. So when you're approaching these patients with penetrating injuries, you really want to consider the mechanism as well. So this is a common theme throughout urgent eye care. You want to know what exactly happened. How fast was it? What were they doing at the time? What sort of material is actually in the eye? Are we worried that is it something inert? Is it something like glass or plastic? Or is it something organic? Is it something like iron? Is it something like copper? What do we actually think has gone into the eye and at what speed? And then obviously you want to look at the extent of the injury. So assessing it, are we looking at just corneal injuries? Are we looking at scleral injuries? How far into the eye has the object penetrated? Is there a foreign body in the eye itself? And then what prophylactic treatment do we need to give to this patient when when we're managing them? And the prophylaxis is essentially some sort of oral antibiotic as well as topical antibiotic before then going towards a primary repair. So we're going to sort of split it up into corneal and scleral injuries. And with corneal injuries, they can actually be quite small. So if you have a very small intraocular foreign body, it can have just gone through the cornea, maybe lodged itself into the iris or the AC or the lens, and that corneal injury can be very, very small. And sometimes it can also self-heal. So if it's a, young patient, the cornea is otherwise healthy, you have a laceration to the cornea, and it can sometimes seal itself with lots of corneal edema, and actually you have a formed anterior chamber and technically a closed globe, but you might want to put a suture in to make sure that the cornea stays closed. Or it can sometimes seal itself with either, for example, iris or lens. So the iris can lodge itself into the wound. It can sometimes prolapse, as you can see into this picture. And depending on what's actually prolapsed through the eye, you might want to manage it a bit differently. So um, with the self-sealing wounds, that can sometimes be, you need to just take a careful approach and looking at the cornea, looking at all the layers and seeing whether or not you can see a laceration go the whole way through. And if there is iris prolapse or if there is lens involvement, that's, it gives you a different consideration when it comes to the surgical repair, which we'll talk about in just a moment. With these injuries, it sometimes can be very difficult to get any posterior view at all. So always do remember to, do a very, very sort of gentle B scan, uh, or sometimes even a CT scan if these patients have come in with a trauma. Can give you any clues as to whether or not that retina is attached. And that won't necessarily change your primary repair, but it definitely is something to consider when you're looking at the prognosis of the patient and what you're discussing with them. When it comes to closing corneal injuries, with these very small ones, there is an option of having a conservative approach. So if they're very small, they've self-sealed, you can potentially even just put a bandage contact lens on, keep a close eye on these patients, and they can be left well alone. But a lot of these patients are going to go to theatre and you're going to close them in a primary way. So what do you consider? Firstly, where is the wound? So does it cross the visual axis? Does it involve the limbus? What sort of shape is the wound? Is it a really clean, simple, straight wound that was done with something sharp? Does it have jagged edges? And then is there any ocular tissue that's actually come forward? So has the iris prolapsed? Has their lens come forward? And then you need to consider what therefore you're removing. So for example, with iris, if it's prolapsed through the eye, it's usually the teaching is that you shouldn't really be putting that iris back into the eye if it started to necrose. So if that iris has started to become quite gray, if there's evidence of contamination, you probably want to be cutting away any prolapsed tissue before allowing the rest of it to go back in. But if it looks very viable, if it's very fresh, if it's very it's a very, very, very kind of recent wound, and they've presented very quickly, then potentially you can replace it entirely. But sometimes any devitalized tissue does need to be removed before it goes in because that's going to be an infective risk to the eye. With the lens, if the lens is involved, if the bag has ruptured, that really in the primary setting ought to be removed. So you can either remove it. So what you would do is you'd close the cornea first, you'd close the globe, and then you'd go back into the eye, and either with a vitrector or a phacoemulsification, remove the lens. And the general teaching is that if you can replace the lens in the primary setting, that tends to do better for the patient, but that obviously depends on the extent of your injury and how much of that bag is involved. With the sutures, you're usually going to be using a tenor nylon. That's what's best for the cornea. And your first sutures will depend on where the injury is. So with limbal involving injuries, you always want to try and close the limbus first because it's really important that you get the limbus to be very, very accurate, and then the rest of the wound will follow. If the limbus isn't involved and you have a purely corneal wound, the apices are sometimes the most useful thing to put the suture in first. So this apex here is a nice corner. It's a jagged wound. This apex ought to have a suture in first so that the rest of it can then be closed quite easily. And then usually people will just put half sutures and then slowly close that cornea up. And essentially it's like any other corneal suture. You want a nice bite either side of the wound, good apposition, and then bury the knot. Obviously, these patients are going to scar, and you're going to, there'll be an induced astigmatism, there'll be scarring, and the management of that after the primary repair will depend on the extent of that scarring and of that astigmatism. Sometimes these patients won't have very good vision without a contact lens, but with a rigid contact lens or a scleral contact lens can sometimes end up with very, very good vision, which corrects for the astigmatism on the cornea. But they can end up with very, very high astigmatisms. With scleral injuries, these can obviously either be the anterior sclera or the posterior sclera. And with the anterior sclera, they're going to be hidden under the conj, but there'll be certain clues. So there'll be this bulging that you can see in this picture here, which suggests there might be a prolapse of the choroid or the uvea underneath. And you do need to be very careful when you're assessing these. You don't want to be exerting any extra pressure. And with the posterior ones, they can sometimes be missed because actually, when you're looking at the eye, the anterior chamber can be deep. But there are certain clues, and we've discussed this in the blunt trauma session, where you've got like a deep AC, an 8-ball high femur, 360 degrees of subconjunctival hemorrhage, and obviously a low pressure. That can all lead you into thinking that there is a posterior rupture. So depending on whether or not that rupture is anterior or posterior, you're going to have certain surgical considerations to take as well. So when it comes to closing these scleral injuries, you really ought to perform a full peritomy, or at least a peritomy enough for you to be comfortable that you have seen the complete extent of the wound. And sometimes if that wound is tracking backwards, you might not be able to get right to the back of the wound. You probably might need to remove some muscles in order to actually close the wound completely. And then again, you want to start off before you're closing off, deciding on what's come out of the eye and what needs to be removed or replaced. So has the uvea come out? Has the vitreous come out? Can you see retina? And these tissues sometimes ought to be tried to be put back into the eye. And sometimes the easiest way to do that is rather than be pushing away, is if you grab the edges of your wound and lift, then everything can sometimes just drop backwards by itself. Um, with vitreous, if vitreous has come forward, you want to be careful that you're not pulling on that at all. So you want to be cutting that right at the face of the wound and letting it drop back because otherwise you're going to be pulling retina with it. With sclera, you tend to close with an ATO. Now, you've kind of got the choice of either nylon or something like a Vicryl. And a Vicryl is obviously easier to use in the acute setting. And if you're not used to suturing, then it might be easier to suture with a Vicryl. The problem with Vicryl is that these are patients that are inevitably probably going to need a vitrectomy at some point. And with Vicryl sutures, the concern is that if the patient were to have surgery quite soon, for whatever reason, then that Vicryl can burst. And sometimes the sclera can reopen. So a nylon suture can give you a much more permanent dependable hold. So if you can, using a NATO nylon or a Prolene can sometimes be a better idea in the acute setting. And obviously, you have to remember that sometimes posterior injuries can just be impossible to reach. So you won't be able to get to them very easily, and you sometimes might not be able to close them at all. So you close what you can, and then let things be for a bit after that primary repair. Now, the prognosis of your injury tends to basically depend on the extent of the injury itself and the involvement of your retina. And the ocular trauma score gives you an idea of prognosis. And 100 is obviously going to be the best prognosis, 0 is your lowest. And the biggest thing that is factored in is that initial presenting visual acuity, and then whether or not there are any certain associated findings. So you give them a score. So if they present with no perception of light, their initial score is 60. That's the highest score that they can have, and then they have higher scores if they present with better vision. And then you essentially subtract a certain number depending on what else they have. So globe ruptures, endophthalmitis, perforating injury, retinal detachment, and RAPD, these will all subtract points, and then your total score gives you an idea of prognosis out of 100. There is a question about whether or not you enucleate or eviscerate in the primary setting, and that tends to be preserved for the very, very worst injuries. So if things are completely unsalvageable, then sometimes that is discussed in the primary setting, and it can very much speed up the recovery because you've removed the tissue and then that's it basically for the patient. But what can be really difficult is that these patients really struggle with the idea of primary enucleation and evisceration because you've not given the eye a chance. And sometimes what they need is a couple of weeks where you've tried a primary repair, they know the eye is completely blind, and then they understand that actually an enucleation or evisceration afterwards would make them much more comfortable if they're in pain. So it can be really difficult sometimes for these patients to accept removal of an organ. Um, Even though we're telling them that the organ is completely unviable, sometimes they need to see that it is not working before you actually remove it. So really primary enucleation and evisceration is really not often done in the context of trauma. And it is really only for the very, very worst injuries. A final comment on intraocular foreign bodies. So these can essentially lodge into any ocular tissue. So with these penetrating injuries, it can find itself anywhere. That's cornea, iris, lens, retina. And what will happen in the eye will depend on the material of the object, the speed at which it has entered the eye, and which tissue it impacts. So for example, will it create a cataract? Is it in the lens? Have you left an iris defect? Is the material iron or copper and leaving you with something like a siderosis or a chalcosis? What speed is it? Has it gone right through to the back of the eye? Is it lodged in the retina? Has it started to cause a retinitis? So in that history, you'll get an understanding of the mechanism and what material it was. Your examination will show you where it is. And then obviously some imaging can help you if you can't see it. So most people will opt for a CT because if it's metallic, you're worried about doing something like an MRI. And CT scans can be very good at picking up these intraocular foreign bodies. And when it comes to managing them, you can either remove them directly with something like forceps, and that if it's in the anterior segment or the posterior segment, anterior segment, you can do that. Whereas with posterior segments, you might be involving the vitreoretinal surgeons, and they can sometimes be using like just an intraocular magnet, which can actually pull the magnetic object itself. And then you want to try and give them some prophylaxis. So you're going to want to give them prophylaxis against endophthalmitis, and we'll have another session in the Urgent Eye Care series talking about endophthalmitis. So you'll want to give them some prophylactic antibiotics. And then the other thing that you want to think about is the development of siderosis or chalcosis. Now, there isn't necessarily anything that prophylactically that you can do other than removal of the body. Siderosis tends to be with iron. So you get these iron deposits, and that can cause a drop in vision from the iron point of view. And then the chalcosis, the extent of the chalcosis depends on whether or not you've got a very kind of high copper content, or if it's something like bronze, it's slightly a lower copper content, so you might have a lower reaction. But that very sort of intense reaction that looks like an endophthalmitis is more with kind of pure copper. Otherwise, you get this chronic sort of chalcosis that can happen as well. So that brings us to the end of this session. Essentially, with penetrating injuries, the main takeaways are you want to know how it happened, you want to know the speed at which the injury happened and what material it is. And if there is an intraocular foreign body, you want to be very careful with knowing where it is and what it is, and then the extent of the injury. So how big is the laceration? How do you want to close it? And then the prognosis is going to vary very considerably. It depends on a whole host of factors, which we've discussed both in this session and in the blunt trauma. So that discussion with the patient is going to be quite prolonged, and there'll be several visits, and it will be several weeks before really the prognosis can be properly determined, because it all depends on the extent of the injury and the involvement of the different ocular tissues. So thank you very much for joining. Please do remember to fill out the feedback, and we'll see you at the future sessions.